Okay, are you ready to talk about diverticular disease? It's interesting. This is a very interesting disease, especially since I worked in the GI area for a couple of years. It's just interesting. I never knew that the bowel could get pockets until then. Um, One of the signs and symptoms that this person may be getting some diverticular disease, and we can look at some pictures here in a second, is chronic constipation. If a person has chronic constipation, um, it's probably because they're not having enough fiber in their diet. And I'm here to just tell you something. As young people, you need fiber in your diet, whether you just take it by a pill or you eat it, because over time, without enough fiber in your diet, your bowel will develop pockets. I don't know why, but it just does. So chronic constipation, change in bowel habits, left lower quadrant pain. Where would you see this mostly would be in the left lower quadrant, okay? And so nausea, vomiting, distended abdomen, fever, if it's an infection. Sometimes what happens is, and let's see if we can go to a picture. Okay, let me go here to this picture. This, no wonder, do you see here, this is not super great picture, but you have the rectum, then you have what's called the descending colon. Believe it or not, this is the descending colon, this is the transverse, and this is the ascending colon. And the reason why is the small intestine connects into this part of the colon, and so it ascends, it goes across, and then it comes down. So you could see that if you were constipated, that stool is going to sit in this area, the sigmoid colon and that first part of the large intestine after the rectum. And what will happen is it will develop these little holes. So from the inside of the colon, you're going to see these little openings. It looks like a honeycomb. I actually saw one person who had such severe diverticulosis, or diverticula, that he it just looked like a honeycomb. And on the outside of the colon, you're going to see the pockets. Now, here's what's an interesting fact about this problem is if they get infected, if the pockets get infected, or any infection in the colon with ulcerative colitis, with diverticula, anything, the colon mucosa or the lining or the tissue of the colon gets thin when it has inflammation. And so if that's the case, and this gets inflamed and the tissue is already kind of stretched out and thin, and it gets an infection, it could just pop right into the peritoneal cavity, and then you have a huge problem. Of course, you have peritonitis probably, right? So be aware, diverticula are just the little pockets. That's a diverticula. Diverticulitis is inflammation and infection in the pockets itself. Be aware of the wording, diverticula, diverticulitis, okay? Let's look, this is actually a real picture of inside the colon, and you can see how it's supposed to be nice and smooth here, but yet there's like little craters or little caves in there where that stool is going to get in there and sit and cause an infection. So we've got to be very careful. And also, this will help you realize that when you eat seeds and nuts and things that don't digest, they like to pop inside these little pocket holes and cause infection. This is a cadaver's colon, and you can see here real life that this person has a lot of diverticula inside their colon. So let's go back to where we were, and we are going to make sure we understand what we're looking at. How do we diagnose this? So I'm going to tell you in the real world, what happens usually is the person starts to be in, they don't know they have it, and they are in so much pain that they go to the ER. And then the ER does a CT scan, and then the CT scan shows them the pockets. And then they go back to the patient and they say, well, you have pockets in your colon. Here's an antibiotic. You need to go see a GI doctor. And that's usually when they would come see us. We would get the CT report from the patient and they say, the ER told me I have pockets in my colon. All right. So you would, and most people would think, oh, you would automatically want to do a colonoscopy and look. No, if there's an infection, you do not do a colonoscopy when there's like a diverticulitis, because I told you that thinning of the tissue inside the colon because of the inflammation. If you put a scope up inside that person, it's going to perforate. It's just going to go right straight through the wall of the colon. You would do no laxatives or Miralax, and see, some people probably are hurting, thinking they need to have a bowel movement, and before they go to the ER, they probably have a laxative, which could also perforate a colon. Um, Gosh, there's just so many things to this, but there's a couple things that I want to point out. When you have diverticulitis, that's the inflammation and the infection, right? Um, it says mild to severe pain. I'm going to tell you, every patient that I've seen has severe pain with it. Their white blood cells will be up. Their colon, like I told you, the tissue changes and it thins out. And what happens is those little nice Hostra pouches. Let me see if I can find a picture of a Hostra pouch. Um, these right here. These little pouches that move the stool through the intestine are called a Hostra pouch. And the little Hostra pouches, when it becomes inflamed, they thin out and they no longer have that nice little pouch. So the colon will narrow and your stool will become more narrow. The shape and the size and the color of stool is important. NG tube, they may have to have that to decompress the bowel. NPO, definitely, if there's diverticulitis. IV fluids, antibiotics. They usually give 2 antibiotics in the real world for a patient who has this. And it can be such a lifelong hard deal that they the doctor, or at least the doctor I worked for, he would say, okay, you're good now, but I'm going to give you a prescription for these 2 antibiotics. And as soon as you start showing signs and symptoms, if it's the weekend, you go ahead and fill the prescription and then you come see me. Okay. When we have inflammation in the colon, diverticulitis, we tell the patient they need to do low fiber. That's an important fact, because if you do high fiber when there's inflammation, it will rupture the colon and it will rupture the pocket. Okay, so low fiber is very important when there's inflammation. You can get an abscess, rectal bleeding. Sometimes there's tunneling inside the colon. Just depends, and perforation is what we really worry about. So here's the thing: what's your diet? You want to go to your book and see what kind of diet this person needs. Low fiber diet is grilled chicken, maybe some white bread, applesauce, maybe some mashed potatoes with no skin. We wouldn't give them a high fiber diet, which would be wheat toast, chocolate, liver, onions, fruit, and veggies. So no wheat when there's an inflammation, right? No fiber. Now, when you have just the pocket, it's the opposite. Okay, if it's just the pocket, there's no inflammation, no infection there, and it says they're having no problems, right? They kind of feel normal. Then we tell them to do high fiber. We tell them to do lots of high fiber to help push the stool through the bowel. And so we encourage exercise, maybe encourage them to eat at certain set times, and then maybe try to go to the bathroom at certain times so that we can help get rid of some of the stool that's down in that lower bowel. Daily bulk laxatives, they can do that, but you would avoid foods that trigger or can get into those pockets. Now, corn, I want you to know corn, nuts, seeds don't really digest. They kind of move through the colon. They're called fibrous foods, right? And so they don't really digest. They move through as a solid form. And so the corn can get stuck inside the pocket. A nut, a seed, a cucumber has little small seeds, believe it or not. That's something you wouldn't think of. A strawberry on the outer part of the skin, we never give it a second thought if we eat a strawberry. But if you have diverticular disease, you're going to give it a thought. And so when you have just the pocket, you go high fiber and look at some soft, high fiber foods. And I don't know why it's cooked cereals. I'm thinking it means like, oats and things like that, like oatmeal. Cooked veggies and wheat bread are some soft, high fiber foods that will help the patient when they have diverticulosis. Let's look at our book, okay? Let's go here. And you already know, we don't have to repeat everything, but diverticula are the little outpouchings of the mucosa that can develop in the colon. And do you remember why? Because you're not eating enough fiber, right? Diverticulosis is the presence of multiple non-inflamed diverticula, which just means the pocket. Diverticulitis, so pay attention to the wording on your test, is inflammation of one or more of the diverticula resulting in perforation into the peritoneum. Yes, this is tough. I'm going to tell you, for the people who have this, eventually they probably want their descending colon removed, part of that. And that's a very hard surgery. I used to work in surgery and I've seen it happen. And sometime I'll tell you about it. Clinically, diverticular disease covers over a spectrum from asymptomatic, uncomplicated to maybe diverticulitis with a lot of complications like perforation, abscess, fistula, bleeding. So we can go for a long time not even knowing we have it because it's uncomplicated, right? Till one day the lower left quadrant starts to hurt so bad that you're like, I got to go to the ER. And then when you go to the ER, they say, you got a pocket in your colon and it's inflamed. So diverticula are common, especially in older adults, but most people never develop diverticulitis because you eat fiber. Yay. So diverticula may occur anywhere. Now, this is an important thing. When I first went to this book and I just typed in diverticula to try to find it, it said in the bladder. Like you can get it anywhere. You can get a little pouching anywhere in the body, anywhere in the GI tract, but it's most common in the descending sigmoid colon area, like I showed you. They seem to occur at weak points in the intestinal wall, such as where the blood vessels pass through the muscle layer. This cause is thought to include both the genetic and environmental factors. So maybe genetically how the bowel is made, we don't know, right? We think the main contributing factors are constipation and lack of dietary fiber, just like I said. So that, just keep that in mind. The disease is more prevalent in Western industrialized populations where people tend to consume low fiber diets and high carbs. Diverticular are uncommon to vegetarians. That's kind of interesting. Other risk factors are obesity, inactivity, smoking, alcohol, and NSAIDs use. Maybe NSAIDs, NSAIDs, if someone uses them long term, they can affect the GI system, right? Because they have a little bit of aspirin in them, and maybe it affects the bowel wall. So let's look down here and just look at the clinical manifestations. Make sure we know most patients with diverticulosis have no symptoms until they do have a symptom, right? Those with symptoms typically have abdominal pain, bloating, flatus, and changes in bowel habits. In more serious situations, the diverticular bleed or diverticulitis develops. The most common signs of diverticulitis would be acute pain in the left lower quadrant. I hope y'all heard that. Distension, decreased or absent bowel sounds, nausea, vomiting, and systemic symptoms of infection, right? Older adults with diverticulitis may be afebrile. They don't present the same way with a normal white blood cell count, and they may just have a little bit of tenderness. Diverticulitis can cause erosion of the bowel wall. Remember how I told you it changes the tissue and it thins it out, and perforation into the peritoneal cavity. Ugh. So you see how peritonitis is probably going to play a role in each one of these diseases. We really worry about it. So diverticular disease can be asymptomatic. We already know that. It's based on a history and physical exam. And look, the preferred diagnostic test is a CT scan with an oral contrast. That's exactly right. In the real world, that's exactly what you see. Abdominal and chest x-ray rule out other causes of acute abdominal pain. So maybe they're going to check everything. Here you go. Here's some foods that you need to know. A high fiber diet, mainly from fruits and vegetables with a decreased intake of fat and red meat, is the best way to prevent this disease. High levels of physical activity seem to decrease the risk. Currently, there is no evidence to support the theory that diverticulitis can be prevented by avoiding seeds and nuts. And I know that your instructor said that, but you are going to avoid seeds and nuts on this test, right? And in the real world, I don't know why they say there's no evidence there. I have no idea. But in the real world, you got to avoid nuts and seeds, anything with a seed in it. In acute diverticulitis, the goal of treatment is to let the colon rest and the inflammation subside. So sometimes we can do clear liquids, bed rest, and pain meds, but other times they're going to do hospitalization and maybe, antibiotics and things like that. So just keep, if we go in the hospital, they're probably going to be NPO and they're going to be on bed rest and IV fluids and antibiotics. There you go, right there. So here we go. Patients with reoccurring diverticulitis or some severe complications like abscess or obstruction, the usual surgical procedure involves resection of the involved colon with a primary anastomosis. I've actually seen that. It looks very, very painful. So eat your fiber. That's what I'm saying. Provide the patient with diverticular disease with a full explanation of the condition. Patients who understand the disease process well and adhere to the prescribed regime are less likely to have a severe problem or exasperation. Teach them the importance of following the high fiber diet and encourage fluid intake, at least 2 liters a day. The patient does not have to, yes, you do. Yes, you do have to avoid nuts, seeds, and corn. Mark that off this book. You do have to avoid those. A patient with diverticular disease should avoid increased intra-abdominal pressure. Factors that could increase intra-abdominal pressure would be straining at the stool. So if you're constipated, you really want to avoid constipation, right? Vomiting, bending, heavy lifting, weight, wearing tight clothes, weight reduction is important for obese people with diverticular disease. So let's look real quick here, down here. Just always look at the little tables and know you can test the stool for occult blood. Sometimes they'll have a little bleed in there. CBC, urinalysis, barium minima. We're going to just like rule everything out, I think. You are not going to do a colonoscopy on a patient that has inflammation at all, right? Now, sometimes the person comes in for just a checkup. Hey, I'm 50, I'm supposed to have my colonoscopy, and we see this. So they've gone their whole life and never knew they had a pocket. Maybe they're doing good. But a CT scan with oral contrast is really one of the best ways to see it. And remember your diet, your high fiber. When there's just a pocket, we're doing high fiber. But when there's inflammation, we go low fiber. Don't forget that, okay? We may have to have the patient on stool softeners if they have chronic diarrhea. Chronic constipation, not diarrhea, right? So if we have diverticulitis, we're going to do antibiotics. Remember I told you the doctor gave the patient a prescription just to put in their wallet. Analgesics, surgery, it doesn't really say low fiber, but it should, because you need low fiber when you have diverticulitis. And guess what? The patient will know they have diverticulitis. It will be very noticeable to them. All right, everybody. So let's practice what we know on diverticulitis, okay? The nurse is caring for a client with acute diverticulitis who has nausea, vomiting, and rates their pain as an 8 on a 0 to 10. Yep. Which of the following interventions should be included in the plan of care? Select all that apply. So you can stop your video and you can look here at the answer choices. But I'm going to move on to the exhibit here, and I'm going to show you, because this is the way I have to do it. If we look, I'm going to tell you, I'll go through this with you. Their temperature is 101.2. What did I say is considered a temperature with the boards? 100.4. So they do have a temperature. Their blood pressure, 126/70. I'm not too worried about that one. Heart rate is 102. They're a little tachycardic. And respirations are 20, high end of normal. And then their oxygen is perfectly fine. So what I want you to do is go back based on that, and let's see, what are we going to do for the patient? stop your recording, and then we will resume the recording. All right, everybody. Hopefully you had a little bit of time to think. And when we're looking at this, we got to make sure we really pay attention to what it says, what interventions should be included in the plan of care for this patient. Obviously, one, administer morphine as prescribed for pain. Remember, I told you they have a lot of pain. What's wrong with two? Insert a rectal tube to protect the client's skin from diarrhea. You never put anything in the colon, right? And then instruct the client to avoid straining. Yes, remember, we might even need to soften the stool, maintain NPO status, and then start IV infusion of normal saline. If you look over here on the right, acute care for diverticulitis, and it tells you what to do here. And this is important. NPO. More acute cases require complete rest of the bowel, right? We don't want to keep pushing food into a bowel that is already having trouble. And it says, and clients may tolerate a low fiber or clear liquid diet. You always, if you have diverticulitis, you're going low fiber, right? IV fluids to prevent dehydration when they're NPO. And then pain relief meds, right? Opioids are indicated in moderate to severe cases of acute diverticulitis, and preventing increased intra-abdominal pressure. Don't let them strain, cough, whatever. And then preventing increased intestinal motility. So we don't really want laxatives or enemas. No, we might want to, have some soft things going through there. So look, here's the pocket. We already saw a picture of this. I just wanted to show you what UWorld did. And then it says, the most common area for diverticula to form is the sigmoid colon. Inserting a rectal tube or a coloscope or a sigmoid scope may cause further damage or perforation. Y'all better remember that. Don't put anything in there. So let's look at how to manage it. Management of acute diverticulitis focuses on bowel rest, right? NPO status, bed rest, drug therapy. Antibiotics are big, analgesics, and any procedure or treatment that increases intra-abdominal pressure may cause a rupture. So I think I would want to remember these facts. So let's go on to the next. I have one more here, and then I'll send you this, and if there's more, you can have a party with all these questions. Which prescription should the nurse question when caring for a hospitalized client diagnosed with acute diverticulitis? Now, use your thought process. Give yourself a minute. Pause your. Well, I hope everybody answered this one correctly. Do not give a barium enema. Do not put anything in the colon when you have acute diverticulitis. We're going to have a perforation if we do, right? Let me mention this. Metronidazole is one of the antibiotics that they usually treat this inflammation with in the real world, so that's okay. Nasogastric tube, right? We might need to remove some pressure off the colon, and then nothing by mouth. Obviously, you can't put anything in the mouth if you're going to if your colon's not working correctly. So if you look, IV antibiotic therapy, and look to cover the gram-negative and aerobic organisms that reside in the colon and contribute to diverticulitis. These commonly include metronidazole plus maybe even trimethoprim, sulfamethoxazole, which is Bactrim, or ciprofloxacin. Now, I know in the real world, we would give two antibiotics. We would give metronidazole and ciprofloxacin, and the patient was supposed to take them at the same time. So there you go. NPO status, more acute cases require complete bed rest of the bowel. I was going to say complete bed rest. Complete rest of the bowel, and it says less severe cases may be handled at home, and clients may tolerate a low fiber, clear diet. So just know NG suction, IV fluids, bed rest, not complete bed rest. Don't listen to me on that. I hope this helps you with your diverticula, diverticulosis, diverticulitis diseases. I think it makes more sense when you see it in a picture and you really kind of try to understand that you don't want to add pressure to this colon because of the way the tissue is happening. Make sure you know you would avoid seeds, nuts, and corn, and cucumber seeds, and strawberry seeds, and any little thing that has some seeds in it might be important to avoid because you don't want to get them stuck in the pocket. Have a wonderful day.